Good evening, everyone. Dr. Seema, I can hear you. Can you hear me now?
Yes, Dr. Hannah, I can hear you.
Yeah. At
We
last. Good morning, Dr. Anil.
Good morning. How are you?
I'm good. We're waiting to listen to you.
Oh. You are Hannah. Hannah.
Yes, I'm Hannah.
You are in South India.
Yeah, I'm in Hyderabad.
Hyderabad. Okay. I have been to Hyderabad once. Long time ago. Long time ago. Yeah.
So you're from which place?
I'm originally from Mumbai.
Okay.
I went to KEM hospital.
Okay.
And then I was the first batch of masters at Haji Ali. First batch.
Okay.
And then I moved to US in 87.
Oh.
And then that's all I have done, only orthopedics. From 87, I never did anything else.
Yeah, I was the third batch to graduate from, CMC Vellore.
Okay.
And at that time, my seniors had come to Bombay to, to do their post-graduation.
Okay.
So I was assuming also that you must be from Mumbai.
I am from Mumbai. Yeah.
Yes.
I still go back every year almost.
Okay.
Yeah, I go every year back. We do a course in Pune.
Okay.
I take few of my staff members and we do a course in Pune.
Okay.
At Sancheti Institute every year.
Okay. Yeah. Yes.
So we do the course every year. It's been going on well.
Okay.
What time of the year do you go usually to do this?
Always in February, either
Okay.
end of January, beginning of February.
All right. My parents are settled in Pune, so I go to Pune now. So I'll try to see if I can go around at that time.
Okay. No, we are taking this time. We are taking a team of 4 therapists from here, and we are doing instead of doing no lecture, just hands-on course all day long for 4
Is it on
days.
BFR?
It will be, BFR will be part of it. It'll be on managing lower extremity problems. So BFR is part of it. Bracing, casting, BFR, walking. The theme is walking to running.
Nice.
Yeah.
Nice.
Yeah. So we do that at the Sancheti Institute. They have a nice physiotherapy department there. And we do it, we did it for 2 years in a row. Then COVID, 1 year we could not do during COVID. Nobody wanted to attend. So everybody was doing virtual meetings. So now we decided that no more lectures, just hands-on course. The PTs only like hands-on. I don't go to any courses that are not hands-on myself. So
I would agree with you on that one.
Yeah. So now we have decided that all our courses are going to be hands-on.
I think then it becomes interesting for students.
Correct. So
especially the learners, whether it's clinicians or students, it becomes practical and they can apply it also.
They can actually do it, then try it in the clinic, and there's a take-home message every time.
Yes.
Otherwise, you're just looking at somebody's slides.
Everybody, shall we be on air now? Starting. Good evening, Dr. Tandon, sir. He is from Gapio. Dr. Anupam Sibal could not come because of his some very urgent meeting with the former president of Prime Minister of UK. So we'll be just having this on. I believe we are already online. We can't hear you, Dr. Tandon, sir. We can't hear you.
Good evening to everybody, and it is almost time, but we can wait for another 1 or 2 minutes if everybody is still not ready. So welcome everybody, and Dr. Anil Bhave, Jay Thakral, and Hana Rajshekhar, how are you? And
Fine,
we
sir.
welcome also
Hello.
Dr. Anju, our executive committee member of GAPIO, and we also welcome Dr. Arvind and all other delegates. We are sorry that Dr. Anupam is unable to join. And after about 1 or 2 minutes, I think with a brief introduction, Seemaji, you go ahead and do it for GAPIO, and then you start the session.
We'll do that.
And I think you have already tested the slides,
Yes.
and I could hear everybody and I can see everybody. So picture clarity is there, voice clarity is already there. So I think we are all set to go.
Then we have Dr. Raj Prasanna from Chennai also with us, who's one of our, organizers of the thing.
Raj Prasanna,
Yes.
welcome.
Yeah. He's
Thank you. Thank you, Dr. Seema.
Welcome to everybody. And Seemaji, maybe you can go ahead.
Good evening, everybody. A very warm welcome to all the members of the audience, our speakers, our moderators, and all the audience who are here for the second webinar in the series with the topic, the physiology and evidence behind applications of blood flow restriction therapy. In the Presta Apollo Hospital Physiotherapy Departments with GAPIO, welcome everybody to this second webinar in the series. GAPIO is Global Association of Physicians of Indian Origin, a non-profit organization established in 2011 by Padma Vibhushan Dr. Pratap C. Reddy, Chairman of Apollo Hospitals Group. He is the founder president of GAPIO. The aim of the organization was to bring together 1.4 million physicians of Indian origin in the world on one professional platform, along with other medical professionals. This substantial workforce is a valuable resource which can help to mobilize significant developments in the healthcare globally as well as in India. GAPIO has its presence in 50 countries. The members belong to various medical specialities, super specialities, which include several Padma awardees, 20 BC Roy awardees, recipients of national, international awards, and it is dedicated, or its vision is to improve health worldwide, which is our chairman's vision. Always it has remained. It is basically that we all work together and how we disseminate the information to the people who can be connected. Thanks to COVID, we all can get connected through webinars sitting in any part of the globe. So if we talk of, and I would like to thank Dr. Anupam Sibal, who could not be here to give the welcome address, since he had some very important task in hand, where he is with the former PM of UK, so could not do it. But we thank him from core of our heart to really help us to get connected. And it is his and Dr. Reddy's vision that we all get connected globally to share the information on expanding the scope of physiotherapy. So as the today's topic is named itself, I would like to just put very little, and we would hear it from the person who really practices it. I believe those all who have joined might be really waiting eagerly to listen to him. So as the name suggests, I would just like to give very brief. It's an approach involving reduction in arterial flow to the working skeletal muscles and venous return to the circulation, thus improving muscle mass its activity, and cardiovascular function. We are here to get more information on the mechanism to explain benefits of blood flow restriction, how over the year it has evolved, its instrumentation, different cuffs with difference in width, material, cuff pressure, time duration, frequency, and should it be continuous or intermittent to make the therapy effective. Not only for healthy young adults or athletes, but even for middle-aged and elderly population with sarcopenia, weakness, atrophy, etc. Just to put very brief, I believe this technique originated in Japan by Yoshiaki Sato around the year 1960. And it kept getting attention of researchers to be an alternative intervention for clinical problems in different age groups. We are aware that BFR training is effective as to improve several physiological systems. Physiotherapists, those who use blood flow restriction in their practice, need the knowledge, skill set, and attitude. Improper use of blood flow restriction technique can cause health problems too. So it is required to be done under a constant supervision and guidance, supported with evidence. In today's seminar, we will understand how blood flow restriction technology can be better used to improve the effectiveness of physiotherapy management. We will also get to know the global trends around the technology and its usage within the context of a regulatory environment and an evidence-based practice. This webinar will help ignite a healthy discourse for clinicians and academicians for further enhancing the quality of services and patient care. Now, without taking much time, I will invite our moderator for the evening, Dr. Hannah Rajshekar. She is professor and principal of Apollo College of Physiotherapy at Apollo Health City, Jubilee Hills, Hyderabad. She's also a member of research committee of Apollo Hospital's Education and Research Foundation, having 32 years of clinical experience. And as an academician, administrator, and a researcher guide for UG and PG students, she's been associated with healthcare-related community work, especially on physiotherapy in women health in rural and urban setup throughout India. Dr. Rajshekar has been conferred with many awards, to name few: Mary Macmillan Mother of Physiotherapy Excellence Award, Lifetime Achievement Award, and Distinguished Service Award by Physio Foundation India. May I now request Dr. Hannah to introduce our speaker for the day.
Thank you, Dr. Seema, and thank you for giving me the privilege to introduce our eminent speaker for this hour, for this session, Dr. Anil Bave. When I was going through Dr. Anil Bave's CV, I was so thrilled to tell you such extensive work Dr. Anil Bave has done. And I'm sure that all of us on this platform are going to be, really enriched with his knowledge and practical advice that he will be giving us. So I'd just like to give a brief introduction to Dr. Anil Bave. He is a physiotherapist. Of course, in the States, they call them physical therapists. Is the clinical director of orthopedic rehabilitation and Wasserman Gate Laboratory and chief of strategy for rehab engineering and virtual rehab at Sinai Rehabilitation Center and the Rubin Institute of Orthopedics at the Sinai Hospital, Baltimore in the USA. He has been a practicing physical therapist for the last 42 years. He evaluates and treats patients with extremity dysfunctions like stiffness, weakness, and joint contractures that results from conditions such as arthritis, total joint replacement, limb lengthening, and reconstructive surgery and trauma. Dr. Anil has also developed and patented dynamic casting and bracing techniques for treatment of stiffness, contractures, and muscle weakness. He is certified in various techniques such as ASTYM, dry needling, kinesiological EMG, and blood flow restriction therapy. He is an accomplished researcher and lecturer. Dr. Anil has published significant works, up to 100 in peer-reviewed journals, and delivered more than 330 lectures nationally and internationally. He also contributes as a consultant and reviewer for top 20 journals. And just to name a few, the APTA that we are quite familiar with, the American Journal of Physical Therapy, World Journal of Orthopedics, International Orthopedics, Clinical Biomechanics, and so on. He has also contributed to few chapters in textbooks, for example, in the Principles of Rehabilitation, Gait Considerations and Principles of Deformity, Rehabilitation of Total Hip and Knee Arthroplasty in Orthopedic Knowledge Update, Prescribing Quality Patellofemoral Rehabilitation before advocating operative care, and Pain Management and Rehabilitation. Dr. Anil has also contributed to a number of major research initiatives and current research projects, like developing a customized, low-cost, custom knee and ankle device to treat stiffness and contractures. He has also developed the dynamic biomechanical factors in development of osteoarthritis, effectiveness of functional bracing for various knee functions, and the role of ASTYM in reducing functional problems and gait deviations. And that's not all. He's a recipient of the prestigious award, such as the Jacqueline Perry MD Award of the American Academy of Orthopedic Surgeons, and the Lynn Staley MD Award of the Pediatric Orthopedic Society of North America. I know we'll be really benefited, Dr. Anil, with your topic that you're going to take on the physiology and evidence behind application of blood flow restriction therapy. And each one of us here on this platform are just waiting to listen to your session. Now I hand over the time to Dr. Anil.
Thank you. Thank you for a very nice introduction and invitation to share my experience with all of you. I'm trying to share the screen. Okay. Can everybody see my screen?
Not very clear though.
Is it coming now?
Yeah, but we need to take it a single.
Yeah, I know, I'm doing it. How is that?
Good, doctor.
Okay. So once again, thank you for having me for your meeting today. And as introduced, I'm an orthopedic physical therapist. Most of my experience for the last 35 years has been treating patients with orthopedic problems, both reconstructive as well as post-traumatic. And that's my experience. So we'll focus on orthopedic patients and the use of blood flow restriction therapy for reversing muscle atrophy and increasing hypertrophy of the muscle, especially. And one of the pet problems that I have faced in my life is how do you get the fast twitch fiber, which is a large diameter fiber, which atrophies much faster, to get back to normal. That's been a challenge of mine throughout, because most of our activities, including the activities of daily living, are not dependent on slow twitch muscle fiber all the time. I give you the best example of that if you are crossing a double lane signal at crossing, you only get 21 seconds to pass that double lane signal. So it doesn't matter how old you are, you're 70 or you're 20, you're still expected to walk fast enough to cross that road. So functional activities depend on fast twitch muscle fiber a lot. And our rehabilitation program has not always focused on getting the large diameter fast twitch muscle fiber to activate. And there are various reasons why that has happened, is that the pain, the disability, patient's willingness to engage in exercise, and ability to tolerate such exercise is very difficult for patients when they are recovering from pain or surgery. So that's the biggest challenge we have always faced, and this probably offers a solution that we have not had before. So for this lecture, I have no financial benefit to me or my family from this educational activity. I don't own any stock in any company that I'm going to show you. So moving on, all the results that we talk about, you must have a team. And this is my team. This is my rehabilitation team at the orthopedic. This is our orthopedic, physical, and occupational therapist and some support staff that we have at our center. And it's a large group of staff that we have, about 28 of them. And they are all dedicated, and without them, there is no success. It's a team effort every time. So I always give them credit for every lecture I do. So this is my tribute to them and thanking them for being part of our team. So one of the challenges we have in today's environment with access to healthcare, challenges in economics, is how can we make rehabilitation better, faster, and cost efficient? Better meaning they have to get better results than we gave them 10 years ago. It has to be faster because we don't want patients to be in therapy for months and months and months. And it has to be cost efficient. Every time patient comes to therapy, we are taking time from them. And that time has a value in economics or money. So how can we make our rehab better, faster? And I don't call it cheaper. Cheap is not a good word. So I call it cost efficient. How can we make it cost efficient? So that's the purpose. We know from our previous knowledge that there is something called arthrogenic muscle inhibition. And it's a very complex neural diagram. And basically what you have is, this is an example of a quadriceps motor neuronal excitability right here. And basically you have supratentorial inhibition, and you have a direct neurogenic inhibition for your muscles when you have certain conditions. Well, what are those conditions? The conditions are pain. Pain is a direct inhibitor of muscle function. Joint effusion, there is multiple literature on this topic where if you inject simple saline solution into the knee joint at about 55 cc's, you cannot lift your leg up straight leg raise. You lose all your ability. Published in 1972 in Journal of Bone and Joint Surgery. So joint effusion is a significant inhibitor of muscle function. Instability by itself is an inhibitor of muscle function. When patients have surgery and the tourniquet is for longer duration with higher pressure, that can have inhibition. Age has inhibitory effect, and habitual limps lead to certain muscle weakness, such as abductors of the hip or quadricep muscle or plantar flexors. So we know that there is significant inhibition that's coming from central cortex, from spinal cord, but with direct synaptic inhibition. And some of these are related to the age as well as the limb factors. So because of that, this is what we get. This is an example of a osteoarthritic patient between age 55 and 72. And on the side that they have OA, they are 50 to 60% weaker as compared to their opposite side. So their opposite side considered normal? No, but whatever their opposite side is, they are about 50 to 60% weaker when they are having OA. Now imagine that patient then gets a total knee replacement. So you start with 50%, and after total knee replacement, you go down to 10%. And then you have residual problems. And it's the largest group of patients that have this surgery. 1 million total knees happen in the United States every year. And in worldwide, more than 5 million total knee replacements happen every year. It's a big group of patients, and we don't have good answers for them. When we looked at our own results in terms of why do patients come back complaining after total knee replacement, 40% of the patients had quadricep weakness as their complaint. Quadricep lag, difficulty in getting the quadricep strong, and that reflects in their function. So what do we do about it? The cost of this atrophy of the muscles is significant. In the post-surgical patients, this can add another $4,000 in value, or in a non-surgical patient, it can add about $3,500. So the economics are very strong in terms of not allowing this prolonged atrophy or persistent atrophy of the muscles to occur. It's a typical example of a post-operative patient inhibited by pain, swelling, some instability, poor muscle function before surgery. All of that is there. Poor extension. She has full passive extension, but poor active extension, poor active flexion, and not moving well. This is what we are dealing with. This is a case of mine. I treated through the whole spectrum. This is a goalie going into the girl's leg, into the knee, and basically dislocating her knee completely. So if you look at her in the emergency room, you can see the leg is totally disfigured. It's hyperextended. It's gone in significant varus. And she has basically PCL, LCL, MCL complete and ACL partial rupture. So every ligament in her knee is torn. It's basically a dislocated knee. The only thing that is intact is capsule and nerve and the artery. Luckily, they were intact. So when these people get reconstructed, sometimes they can have setback like this. How do we get them to here? Within 3 to 6 months. This muscle, after this type of dislocation, is everybody understands what is grade 2 muscle, meaning that they're less than 10% of their normal strength. How do we get this person from that to what she's doing now? This is explosive ballistic activity on the leg step. How do we get them to do all these things? Or do a single hop for distance, which is one of the tests you will follow. How do we get that muscle coordination, just not in the quadriceps, in the entire lower extremity, where the patients can actually do these type of activities, including, I think I'll play this also, lateral jumps. So we have a strict criteria when you can return to sport. And in order to get them within that 6-month period, your quads have to be super strong. They are not to be just grade 5. Grade 5 is a wrong way to measure these. You have to measure them with the instrument or a dynamometer, and you got to get them as strong as they can be. So how do we get them there? And then eventually return them back to, eventually get them on a football field in the shortest period of time, and getting muscle activation in not just in the quadricep, but in the entire lower kinetic chain, and start early. So that's the challenge, that's the problem. And this is a case of total knee replacement. How do you get a patient to walk like this so well at 6 weeks from surgery? You have to get people results that they want within the shortest period of time, or have them do activities such as this. And the reason I show this case always is that she's had previous surgery. You can see her scar even on her lateral side of her knee. She's had a plate there, and then she had a total knee. So these patients are at more risk to have muscle wasting, and you need to get them here. And this is our goal. This is our ultimate goal. And it's a continuous process of improvement your rehabilitation protocols to get better results. You don't want this. This is a color-weighted atrophy of the thigh muscles. And this is a patient who developed significant pain after ACL and lateral meniscal repair. And she was a collegiate athlete, and she just didn't do the rehab the right way. And this is what the atrophy looks like. And there is a lot of evidence that basically this muscle tissue is then replaced by fatty infiltrate. We call it intramuscular adipose tissue, IMAT. And most of the people start getting more IMAT. And if you do a cross-sectional CT scan, you will see that in these patients. But we want this after a ACL repair. We want muscle atrophy, hypertrophy like this. And you can see the outline of the vastus. Just excuse me for 1 second. Excuse me for 1 second. I'm in a meeting. Can I call you back? Okay, bye. So this is what we want. And how do we get here? Well, we are getting the results that we want through this. So what's the problem? That muscle atrophy is very common in knee in post-surgical patients. The American sports guideline is 60 to 70% of 1 RM. And if you want real strength gains, you have to go up to 85% of 1 RM. Everybody knows what 1 RM is, one maximal repetition. So if you're able to lift 100 pounds of weight, they want you to go to 60 to 70 pounds of weight and do multiple repetitions. And then if you really want to hypertrophy, you have to go to 85% of your max and work out. Problem is the high loads are painful and difficult for patients to achieve. This is a paper that shows where we were at. Only 1 patient out of 5 achieved symmetrical knee function 6 months after primary anterior cruciate ligament reconstruction. This is the problem. That means that we are not getting symmetrical knee function in our patients despite our best efforts. And then my favorite topic is we have ignored this completely. Fast twitch fiber, which is a large diameter fiber, requires more work. The rehab programs don't address it. So critical to all functional activities. If movements cannot be achieved quickly, it will not be used in function. It is faster to atrophy and harder to recover. And rehab protocols generally do not address it. If we do the standard rehab protocol, we are not recruiting fast twitch fiber most of the times because we're just not doing it. I mean, I've done it also. There are 4 methods to address fast twitch muscle recruitment. Number 1 is blood flow restriction therapy, and I'll explain that in my lecture. The second is neuromuscular stimulation, but has to be really maximally tolerated. The third is maximal intensity eccentrics. Imagine that to be done by a post-op patient. Can't do it. Or fast movements such as limb perturbation or rhythmic stabilization. Well, 3 and 4 are out right now. So only we got 1 and 2. And the skin sensitivity, patients who can tolerate NMES to that level, when I say NMES, I mean neuromuscular muscular stimulation, they can do better with it. But BFR training has certain advantages, and that's what we're going to talk about. So what is blood flow restriction therapy? I did this search about a year ago. And if you hit blood flow restriction therapy, you get 13 million hits on Google as soon as you open it. There are close to 600 articles I checked last year in PubMed in last 10 years. There are actually maybe more than that. There are lots of randomized controlled trials. It is probably one of the highest number of research articles and randomized controlled trials in the entire literature of physiotherapy. Probably. I don't think there is anything in large quantity, not manual therapy, not muscle stimulation, not any technique of manual therapy, nothing. This has the highest number of publications. And it's anecdotally, it's working in many, many centers. So what is blood flow restriction therapy? So blood flow restriction therapy is very simple. You have to use a tourniquet. The tourniquet has to be as high as you can put on your upper limb or lower limb. You have to inflate the tourniquet, but not inflate all the way. You inflate so that you can produce a 80% occlusion of the arterial flow for the lower extremity and 50 to 60%, 40 to 50% for the upper extremity. But when you are doing that, you're doing almost 100% venous flow reduction. So venous flow is 100% reduced. Arterial flow is 80% reduced to 70% reduced, depending on the patient tolerance for the lower extremity, and 40 to 50% for the upper extremity. So how does BFR offer a potential solution? Because all the literature is now suggesting that if you do BFR with only 25 to 30% of 1RM, it leads to significant strength and hypertrophy at lower loads. So at lower loads, you can get significant hypertrophy in the muscle. And there are many ways to do it, and we'll show you all the ways that you can do it. So what does BFR, or I call it BFRT, the short form blood flow restriction therapy, create? It creates a hypoxic environment. You know, it's like going to, in India, is going to Ladakh and training in Ladakh, and then come and play in New Delhi. You're going to do better, always going to do better. The entire US Olympic team doesn't train in summers, they train in Switzerland at Matterhorn Glacier. Why? Because its glacier is at 12,000 feet. So they're working really hard up there. So when they come back to 5,000 for the Winter Olympics or 6,000, they're doing better. The BFR promotes anaerobic metabolism under low loads, important, and allows the recruitment of large, fast-twitch muscle fiber, which is the key, in my opinion, for getting people better. The possible mechanism of actions are fiber type recruitment, muscle oxygenation, metabolic accumulation, growth hormone response, and stimulation of protein synthesis. These are all, again, some of these are not human responses. Some of them are human responses. Some of them are animal responses, but animals can't exercise. They are usually put on a treadmill to do it. But this is what the possible explanation for some of these is. So how did it get started? It started in Japan. In 1960s. They noticed that monks that were kneeling at the temple felt this different sensation in their calf muscles. So in 1966, Dr. Sato tried to reproduce this symptom with a controlled cuff and started evaluating results of strength and hypertrophy, first in sumo wrestlers. Sumo wrestlers were the first to use this. But it stayed in Japan for a long, long, long time. It never went outside Japan for a long time. Most people really didn't practice it in rehab. Nobody was doing it in rehab until this guy. This man came about. This man is a physical therapist at San Antonio Intrepid Institute. It's an Army Institute for veterans who have limb salvage problems, people who get their limbs blown up. And he created this company, which is very unique. It's called Owens Recovery Science. And his main mission was, all wars create good science sometimes. So his main mission was, how does he rehab some of these people that have been blown up their legs with IEDs or massive gunshot wounds or bomb attacks or hand grenade attacks, and how does he get them functional again? So that's how he started. So he took people who were really weak and significantly dismembered and started working with them to get the results that he was getting. Then in sometime 10 years ago, I think 8 or 10 years ago, this is American football players. And they are usually worth $100 to $200 million to a team. And this guy, I will not give the name because it doesn't matter. He was sitting on a bench for a year. And because of atrophy, couldn't reverse his atrophy, couldn't play the position he was playing. And in Houston, they had heard about this Johnny Owens guy and they started using it on him. And within 3 months, he was back on the field and he has never looked back. So that kind of gave the fame, and everybody in sports started noticing this, and all the teams started noticing it. and it started getting popular about 8 to 10 years ago. So that's the history, some of the history, how it became very popular in the United States. There are other stories in other countries, but this is how it happened here. So basically, as I said before, cuff pressure guideline is arterial occlusion is 60 to 80%, venous occlusion is 100%, and for the upper extremity, it's 40 to 50%, and venous occlusion 100%. One word of caution, the tourniquet only goes as high as possible in the upper or lower extremity. Just because you are strengthening a calf, it doesn't go to mid-thigh level or just above the knee joint. It always goes proximally as possible. The question is, are all BFR equipment same? If you run a research or a search on Amazon, this is what you get. You get all kinds of equipment, starting with just bands that you apply for reducing blood flow to very sophisticated equipment. And the question is, what should a healthcare professional use and what is safe for our patients? Because there are certain things that you shouldn't do it with. But there are people who go to gym, put bands around their arms and legs and strengthen. And they usually tolerate it because they are very strong athletes. But is it good for a patient? I don't think so. So there's been a lot of work done on this. And this is one of the work that was done on interface pressure and the pressure response to different types of systems. So basically 18 males participated. They were all normal blood pressure, body mass was pretty good, 88 kilograms, and they were all recreationally active people. And they used 3 different types of methods. One was a rapid inflation system that was fixed. The second is the method which was automatic personalized tourniquet. So it adjusts, it's a Doppler-based device, so it adjusts your occlusion based on your contractions so that it's not constant, but it's adjusted to 80% if you want on every contraction, which is what we use in our hospital. And a manual handheld high-intensity pump was used. And they looked at the pressure gradient as well as the pressure responses from the patient in terms of pain. So what did they find? Well, the one that is in the center, which is the Doppler-based method of inflation of the cuff and monitoring, gave the least pain response for all 4 sets. You do 4 sets of exercise. I'll show you that in a second. So if you see statistically significantly, pain was much less at set 3 and 4, and they were able to finish all sets when you had a more personalized Doppler-based tourniquet that was used. Also, the reported perceived exertion was the least when you use the more personalized tourniquet method, which is what I recommend for at least in the patient population and not in the super athletic or the people who go to gym and work out. So what was the conclusion of that paper is that BFR system that automatically adjusts during exercise to a mean arterial pressure was a better system and likely the most beneficial and may have positive influence on patients' tolerance and adherence to BFR. Because you want the patient to tolerate the exercise. Most of the strengthening exercise at 20% of 1 RM is done 75 reps each exercise. And we do 3 to 4 exercises to get stronger in their leg. So they have to be able to tolerate this. So the width of the cuff matters and the automatic adjustment matters for especially patients. And that's how it looks like. So every contraction, there is a pressure modulation that occurs because it's connected to the cuff, which is Doppler controlled, automatically adjusts the pressure through the entire cycle of exercise. And that's a better way of doing this, in my opinion. So what are the guidelines? The guidelines for doing a BFR with strengthening exercises is frequency 2 to 3 times a week. The loads are 20 to 40. 40 is a high end, 20 to 30 is low end, which is what we do. Restriction time is 5 to 10 minutes per exercise. And each exercise is done in a fashion of 30 reps the first time, and then 15 reps the 3 times, totaling 75 reps for each exercise. We don't do more than 3 or 4 exercises or sets of exercises. And each exercise, we give a 30 to 60 second break in between, where we deflate the calf between each set, not meaning each set, but each exercise. So when they have done their 75, they get a 30 to 60 seconds deflation followed by inflation again. And the execution speed is always 1 to 2, 1 concentric, 2 eccentric for the weighted exercise. So that's what it's recommended. That's what we have been doing. And we want to have the 4th set to be difficult, because if it's not difficult, then you have to increase the load so that they can, next time they come, they are able to execute that. What's the evidence? Well, here is an example of BFR done at 20% compared to regular control exercise. And you can see the improvement in cross-sectional area and strength. This was original work in 2004 by Takada that shows that significant changes in both the strength as well as cross-sectional area happens when using BFR at 20% of the 1RM versus control group, which was standard rehabilitation exercises. The lactate accumulation is high with BFR as compared to regular control. And you can see the peak that happens right after the exercise. And you want that lactate for muscle hypertrophy. You want the lactate accumulation for muscle hypertrophy. There's a progressive increase in muscle activation, first to final set. You can see green is BFR, and you can see that there's progressive activation of more because you're demanding more, you're doing more, you're asking muscle to work harder through BFR. So you have that. And then you have also systemic hormone response, both testosterone and cortisol. This was done by Cook in 2014 that shows that it's increased also compared to a 70% squat bench versus BFR versus control. So there is some hormonal response to it also, including a growth hormone response, which is BFR with exercise in the purple or blue, shows the highest growth hormone response versus just a tourniquet or low load exercise. So red is tourniquet, green is low load exercise, and the bluish purple is your BFR with exercise, showing significant growth hormone response. BFR also can be done in early postoperative period in a passive mode. We call that a cell swelling mode, meaning you can use it just to have patient at rest and allow BFR to function. And the restriction interval is about 5 minutes interval, and there's rest in between the pressures. And usually you need 70 to 100% of restriction. I never have done 100%. I do 80% even for this, and restriction is continuous. And there's not a lot of evidence, but people are using it right now in the early, like if you have surgery, within a week of surgery, as soon as the wound looks healing in the knee or ankle, they are using this. And we have not done it. I don't have that much experience in this area of doing first 2 weeks because some of our wounds don't heal for 2 weeks. So I'm a little careful, cautious about it. But people are showing evidence that it's a better way of reducing atrophy of the muscle in the leg. And the last one is very interesting for older population, which is BFR with aerobic exercise. And this is usually intensity less than 50% of your max. Restriction time is about maximum 20 minutes. And the exercise mode is usually bilateral, and exercise mode is cycling or walking. So you can walk if you have the treadmill, or you can do bicycle with bilateral or unilateral, depending on how weak your muscle is. This is well tolerated by older patients, and we use it a lot in our patients. And this is some of the early work done by Abe in 2011 that shows that there is improvement in strength, knee strength, green being again the knee flexor, knee extensor strength compared to normal. as well as the cross-sectional area is significantly better. Percent changes are better than control group. The sit to stand, ability to sit to stand for elderly also improved significantly with aerobic exercise, and timed up and go also improved significantly. There's a lot of work done. This is a knee-OS study that shows a significant improvement in 30% BFR 3 times a week for 4 weeks, showing a improvement in the leg press ability. And the last one is after arthroscopic surgery at, I think, 4 or 6 weeks, that shows a significant improvement at 0.015 significance, showing occlusion has a better result with arthroscopy. So there's a lot of evidence here. This is a randomized controlled trial of 26 patients, a 6-week trial that showed that low load BFR training led to greater increase in muscle strength and limb circumference. And BFR training had similar or better results, both proximal and distal muscle groups. So one of the things that we have not talked about is if you apply a tourniquet in the groin or below the groin, are you getting any effect on the hip musculature, which is mostly above the tourniquet, as well as are you getting results on rotator cuff? And there's evidence that I use it all the time for my total hip patients who are weak in their abductors, is to actually apply the tourniquet and have them go through a total, I call it closed kinetic chain exercise for the entire limb, and work on the some of the abductor and hip extensors through BFR. So there is enough evidence of systemic response to that. The contralateral rim, I have not seen any evidence of that, but that's this there. So there was with the slide here, the involved limb showed knee extension torque improvement, total work improvement, as well as thigh circumference improvement in all patients. This is a second study. This is quadriceps strengthening with and without blood flow restriction and treatment of patellofemoral pain. And this was a double-blind randomized controlled trial of 79 patients. This was done in 2017. That also shows similar responses within 8 weeks. So very quick responses are being obtained by adding blood flow restriction therapy to rehabilitation protocol in many of the patients in orthopedic problems that we see both in upper and lower extremity. And there's no evidence of rhabdomyolysis. There's always this thing about, oh my God, we are restricting the blood flow. Are you going to cause muscle compartment syndrome? Are you going to cause rhabdomyolysis? If you do it carefully, correctly, and I will talk about it at the end of my talk, how we titrate the dosage, you don't really see any change in creatinine kinase or lipid peroxide. Both of those are markers for rhabdomyolysis, and they have not been shown to have changed. Is BFR dangerous? Yeah, sure it can be. So we avoid cardiac compromised patients. We avoid patients who have unstable hypertension. We have done people with hypertension, but we have not done with unstable hypertension. If they have active DVT or DVT management, we have not done it. People with significant varicosities of their veins, we have shied away, or we have done more aerobic protocol for them and not strengthening protocol with less pressure. Neuropathic limbs, I haven't done. We have done few patients with radiculopathies that have a permanent weakness. I have no experience with polio and how to use BFR on it. I don't know. I've never done it. One of the things that we learned over the last 6 years of use is that you don't want to use it when patients have severe blunt muscle trauma. So let's say you have an athlete that gets injured in their knee and they have a very bad knee strain, or they have a scope done, but they also have blunt trauma to their thigh or their leg, and they have actual ecchymosis and blue and black leg. You don't want to use it because what our personal experience has been that it actually slows down the recovery of the muscle. So you have to wait for that effect of blood trauma to go away before you start using it. And definitely not for vascularized skin graft below the tourniquet. We have definitely not done it for any patient. So there is we have a sheet that we use for rule out. We call it risks and contraindications. So some of these are contraindications, and some of the risks we have the patient sign a consent if they are in the risk category. But if they are in the contraindication, we will not do it on those patients. So we have very strict criteria. You know, it's one thing when you are an athlete and you are healthy and you have no problems and you use BFR any way you want. And it's one thing to take a patient who is compromised and use it. It's a totally different ball game, and we have to be aware that we can't apply. Many times what happens is, unfortunately, in our world today, we apply the physiology based on two things, and it's very unfortunate. One is all the universities publish papers on students. Students are their subjects many times. So they publish papers on the subjects who are healthy, normal, young students. The second thing is they apply what works in the field of sports medicine directly to patients that come to you in the clinic setting who are much more disabled. So we have to be really careful how we apply it. So this is a technique. This is my own physical therapist. He had knee injury, so he's doing it himself. So basically, it's a tourniquet that goes as high as you can go. You have to put it tight enough so that it's close to the leg. Then you have to take calibration by lying down in bed. So you connect the tube that connects to the tourniquet, and you basically inflate it. That's the technique. The exercises that go with it, there are multiple exercises. This is a simple knee extension exercise under BFR control. And basically he found his 1 RM, and then he's now doing 25% of 1 RM in a limited arc because he had restrictions placed on his terminal extension due to a injury to his knee. So he's doing through the range, and then he will do the same thing through the leg press. Again, finding 1 RM is not that difficult on a leg press or a knee extension machine. And leg press is a total leg workout instead of having just a workout on the one muscle group. So I like that for our patients. So that's another setup. The third setup is just doing a straight leg raise with a 5-pound, 10-pound weight to recruit both the long hip flexors, quadriceps. There are many exercises. There are thousands of exercises you can come up with. That's not the point. The point is that it can be done. And you can see the cuff pressure and how it's going about. In the leg press, he was allowed to do more than he was allowed to do. Sometimes in early post-operative phase, we will also use it with muscle stimulation. That's the thing that we have been doing recently. So BFR with blood flow restriction is a common thing in our center. And I'm going to show you a case. I've used it on hundreds of patients, but I want to show you the most difficult case there can be, because that tells you everything, the story about BFR. So this is a patient who had a well-done total knee. He was doing very well. And he suddenly had clinical stiffness, very painful, hot, significant difficulty in walking. So his labs showed that he was infected. And this was a systemic infection from his dental flora, probably. So we had several cases of joint infections after patients taking COVID vaccine. That we are reporting on that, but we had this case. He was a dentist himself, and he got this right after. So what's the solution for that? This is basically you have to rip out the entire components. You have to put a drain inside the joint. You have to treat it with antibiotic cement. It's called spacer. And then you got to get them IV antibiotics for 6 weeks to clean out the joint, and then hope for the best. In the between, because of the infection, he also had attenuated extensor mechanism. So he ruptured his quad tendon partially, and that had to be repaired. So you know all as therapists that if you get an extensor mechanism repair, you have to immobilize that patient. So he was immobilized for almost 6 weeks in a long leg brace and not allowed to move because of the infection. The spacer has to heal up and his extensor mechanism had to heal up. So the only thing he could do was straight leg raise in a brace and muscle stimulation. We did that. Then after 6 weeks, we got him to start working with us. And this is what his X-ray looks like, a total knee. The metal is intact, but here it's ripped out. And this is all antibiotic cement impregnated with plastic spacer in between. So we call this a spacer surgery. It acts as a total knee. But imagine the trauma his knee had taken through this whole process. Multiple debridements, removal of prosthesis, immobilization. So his quads, when I first saw him, he had restricted range of motion, and we have treatments for that for another lecture time. But he also had significant weakness of his quadricep muscle, grade 1 plus maybe, or grade 2, somewhere there. So he was very weak, and we started earnestly working with him with BFR. And that's his final result. This is within 3 months of treatment of his starting with 0 to 35 degrees of range of motion, with quad function where he couldn't do a straight leg raise. His quad function was less than 2. And that's what happened. But more impressive really is what happened later. We did his isokinetic test, and he's only 31% weaker as compared to the other side. We never would get him to function 100%. I don't think you can get that.
Perfect, thank you.
But we got him within 3 months of starting rehab to a function where he could play golf routinely, and got his strength significantly better, where he was, if you look at this isokinetic graph carefully, he's putting out almost 70 pounds of foot-pounds of torque, or about 50 Newton meters of torque in his quadriceps and hamstrings. His hamstrings are actually stronger than the other side a little bit, but his quads are still a little bit weak on the other side. But you have to compare to where he started with. He started with grade 2, less than grade 2 muscle in his quads, grade 3 muscle in his hamstrings, very weak abductor muscles, hip extensor muscles, plantar flexor muscles. So we did the total body rehab, total lower limb rehab for him. I mean, it didn't just focus on one muscle. But first we started with some of the weight and TheraBand exercises with BFR, followed by close kinetic chain exercises with BFR to get the whole body worked. And that's the result. You know, he's 1 year out of, and hopefully he never comes back to me for any more therapy, and hopefully he lives a great life. He's actually going for a hike in Nepal this summer. Hopefully he can make it. So this is another patient of mine, total knee replacement. And that's his left side, and that's his right side. And this is a total knee replacement. Guess what his age is? What do you think his age is? 72 years old. 72 years old. Not everybody is like this. Not everybody gets where I'm showing you. I'm showing you the worst case before, and this is the best case scenario. But it can be obtained. So there is a lot of evidence, a lot of work. You have to be careful how you use BFR. It is not a solution that you offer your patients where you just put it on their leg and walk away. Don't ever do that. Monitor your patients. Make sure that they're supervised. This is not a tablet therapy. You don't take physiotherapy as a tablet. You take physiotherapy as an active intervention. And you have to treat it like that. And you have to monitor patient, because you want to, sometimes patients have abnormal response. You want to slow them down. You want to stop them. You want to reduce the pressure. It happens. The third set becomes very difficult. Then you have to take the pressure down. Sometimes you have to reduce the repetitions. Sometimes you have to take the cuff off completely. All those are possible, number one. Number two, what I've learned, never do isometrics with it. Always do concentric exercise or concentric eccentric, but don't do isometrics. Isometrics just build too much pressure in the muscle. And I've learned that older patients don't tolerate it at all. So I don't do it, even for my younger patients. We don't do isometrics. We always do, we do the more standard isometric, isokinetic or isotonic work, and both in open chain and closed chain. We do both of all of that. If patient has hypertension, my personal preference, because let's see you are hypertensive, your systolic is high, then your total occlusion pressure will be high. So 80% of that will be too high. So what I do is I still lower it down to below 180. So I go between, my preference is to go between 120 and 180 for all patients, depending on their tolerance. I don't go past that because it's not possible to take a hypertensive person and have them do their occlusion at 80%, it would be higher than 180. So I never do that. That's my fail-safe mechanism. I never start my patient at 80% for my lower extremity. I start at 50% or 60%. I sometimes will do the cell swelling protocol a couple of times just for them to feel what occlusion feels like before I actually start exercising with them. So these are some of the precautions we have taken. However you like, do not increase the pressure in the upper extremity more than 50% ever. It's not a good idea. We have never done it, but we have heard other people doing it. In last 6 years of using this, 5.5 years, we had one patient who had compartment syndrome-like symptoms. So she went to the ER and had her compartment pressure measured, but she did not have compartment pressure raised. So she was just admitted and released after 2 days, but it was a one case out of hundreds, thousands we have treated. So it's not very common. Select your patient carefully. You have to educate the patient well when you do this. Don't just apply it on their legs. We have learned that also hard way. Don't just offer them something that is new and sexy. Like, everybody now is doing dry needling because it's new and sexy. Then before that, we were doing something else. It's new and sexy. So the new and sexy in physiotherapy is not uncommon to everybody. So don't educate the patient well. This is a patient. This is not an athlete. And even if it's an athlete who is injured, he's still your patient. So that's what I recommend. And I truly believe in the total chain or lower limb exercise and not just focus on one muscle group at a time. So when we create our exercises, they're always based on total limb function, which is what is important in my opinion. So I made up this is a international sports recommendation for post-ACL recovery period. And you can see there's a post-op period, there's an endurance period, there's hypertrophy, strength, and final return to sports. And I did this so that we start with NMES, and within 2 weeks, we move to NMES with BFR or just BFR. Then we use BFR with progressive loads in closed chain, followed by open chain, followed by heavy load ballistic activity to get them back to full function. So it's a long process. It shows here it's very long. It can take anywhere between 15 to 23 weeks. You don't want an ACL patient to return to sports for 7 to 9 months anyway. Running we allow at 4 months to 5 months. We do it sometimes in anti-gravity treadmill to get them faster. But we made this up based on the graph that was published by the international sports people, This was a clinical commentary paper of restoring knee function. And this is the recommendation we make to all our patients. And this is how we follow in our sports injury patients. For our other older patients, we go more by patient responses and what the goal of treatments are. You're not going to get them 100%, but are they walking better? Is their tug improved? Is their aerobic capacity improved? Is their walking speed in my opinion, walking speed is a sixth vital sign. We should all use walking speed as a sixth vital sign. When you have better walking speed, you are functioning better. So we use walking speed as an indicator where we do both the 6-minute, 2-minute, 6-minute walking speed, repeated chair rise test, a tuck test. All of these are standard battery of tests for our older patients to do so that we can document their improvement. And then we will do isokinetic testing when appropriate for the quadricep muscle. Not every patient. We will do that, but we'll do it on majority of our patients if we are targeting certain muscle group. So that's the talk. If the therapists on this are interested, we are coming to Pune in 2023, February 15th through 18th. We will be doing a hands-on workshop in Pune at Sancheti Hospital and Physiotherapy Academy. And I'm bringing 3 of my colleagues with me from United States to do this. And we decided to do this totally no lectures, only hands-on course. And of course, the BFR is very much part of the education. Not everybody can afford the type of device we use in our center all the time. But then how do we use a less expensive device and still be safe is also a technique. And we use other devices also, and we have experience in other devices and how to use them and safely. That safety is more important than beauty all the time. So we do that, and those who are interested can work on this. And finally, I want to say thank you to all of you and Seema, Dr. Seema, for inviting me to this seminar or webinar. And I hope I did the justice, and I will take questions. Thank you very much.
Dr. Anil Bhave, for such an elaborate explanation. And I believe, and I see the numbers, all our viewers are just hooked with you throughout the session, and it has really made many of our concepts clear. I believe all will agree with me on the same context that yes, knowing about the technique and really now understanding it with evidence, it is really an honor to have you and you sparing your time for all of us. And I believe we all can see that teacher in you who's ever been giving. So I thank you so much. Along with that, I thank Dr. Hannah for moderating the session. Now, I believe without taking much of your time, now I would introduce our question and answer session therapist with us. One of them is Dr. Raj Prasanna, who is head and chief of physiotherapy and rehabilitation in Apollo Hospitals, Chennai, with 22 years of professional and clinical experience, including academics and research activities. His areas of expertise are pain management, orthopedic and musculoskeletal rehab, sports rehab, neuro and cardiac rehab. Dr. Raj Prasanna completed his doctorate in physiotherapy in 2015. He's also a certified neurodevelopmental therapist along with a certified kinesiotaping therapist. He's advisor of Federation of Physiotherapists, committee member and advisor of Madras Institute of Magnetobiology, and member of Board of Studies at Savitha University, Chennai and MGR Medical University, Chennai. Along with him, we have another eminent personality, Dr. Nilambari Thakral. I'm really thankful to her with very minimal acquaintance too. I requested her to be a part of our program and she agreed. Dr. Nilambari Thakral is a registered physical therapist with 23 years of experience in acute care, subacute care, and outpatient rehabilitation. She has worked as a clinical instructor for physical therapy and has obtained her orthopedic manual therapy certification from Auckland University and completed her doctorate in physical therapy from Utica College, USA. She, with many certification trainings, is also blood flow restriction certified, along with the pain management, Pilates, cupping therapy, vestibular rehab, and she has many more to her credit. Now, over to you both for question and answer session. For me, I found many of my questions have been really answered well, Dr. Bhave, but still there are many people who might be really interested in still asking you questions. So I request all who want to ask questions, kindly put it in your chat box. It'll be much easier to put it forward across to Dr. Bhave and the team. Over to you. Dr. Thakral, just unmute yourself, please.
Can you hear me now?
Yes.
So my question, first of all, I am very, very impressed with Dr. Anil Bhave for doing such a wonderful presentation. I had the opportunity of doing this. I was introduced to BFR 2 years ago by one of my co-workers. And we had a patient with a knee. He had a knee replacement done a couple years, and then he had multiple manipulations. He was a retired police officer. He loved to work out. And he had significant atrophy in that muscle. As Dr. Bhave was talking about quadriceps and how much atrophy it can develop so soon. So I was kind of lost for ideas at that point. And another therapist who was there with me said, why don't you try BFR? So that's who he was the one who introduced me to the BFR concept. And my first apprehension was, what if I give him a DVT? Because I'm putting a tourniquet on him. So my understanding was kind of limited with the subject. So I decided to work with the therapist because he had his certification then. And he was practicing that with other patients. So on his first day, I took his circumferential measurements and I looked at the single leg squats and how was he doing the leg press, how much he could push. Took some measurements down, range of motion was limited. And I watched the other therapists perform the BFR and I was kind of very impressed with how he was improving. A month later, I checked for the circumference. I did the reevaluation and found significant gain with BFR training. So based on that, this year in March, I went ahead and took the course myself. And I'm still learning. And Dr. Anil Bhave's presentation was very enlightening. And it brought on a lot of questions for me. But at the same time, I'm very interested, Dr. Bhave, in knowing how you went ahead and treated the patient you talked about with the spacer. When did you start the BFR? And how did you, what was the criteria about your progression? How did you increase repetitions? That was pretty impressive to see how the patient was able to do a straight leg raise that way.
So when we first got him, as I told you, he was grade 2 quads function. He couldn't do a straight leg raise. He couldn't do anything. He had a LAQ or longer quad lag of about 50 degrees. So he really had very poor function. So we started simple. We first introduced him to cell swelling protocol for a day or two, just to get him used to the occlusion at 50%.
Sure.
Then and I do this for many patients. And then I went to 60% and had him do a simple LAQ, but within the range that he had. Then I started with him assisted straight leg raise.
Okay.
Then I added a pediatric TheraBand, the yellow color, to his LAQ.
Sure.
Then I started working in sideline position for hip abductor. Then I started working with him on a 4-inch step up.
Okay.
And then I put a TheraBand behind his knee in standing for extension. Again,
were you using Sorry, were you using BFR with the whole process the entire time?
Yes, all exercises were done with BFR.
And were
Every-
you increasing the repetition maximum with every session, or how were you going
Not
about that?
repetition, but I was changing the resistance.
Got it. I mean, that's what I meant. Yes.
The repetitions were always 30 first set, and then 15, 15, 15, 15. And the resistance was increased gradually. I had to be slow with him because he still had some swelling in his leg and he had just come out of a long leg brace. So I've monitored him very closely for that. He was otherwise very healthy, medically uncompromised, hypertension under control, taking regular medicine. So it was not like he had medically compromised, but this guy had been on IV antibiotics for almost 8 weeks.
Wow.
Multiple debridement, so he was very weak. But that's how I progressed him, very gradually. But we got the extension lag back. And once I got the extension lag back, we progressed him very fast. Then we went to the blue TheraBand to black TheraBand for knee extension. We started doing leg press on him. We did that was the progression basically. It took about 3 months, the whole process. Okay. And his visits were 3 times a week for 2 months first. And then once he had significant improvements, it was twice a week for last month.
Okay. Do you do anything? What kind of precautions you take, and how? When you start BFR with your fractured patients, like say somebody with a patella fracture, who's also developing atrophy, who's also having quadriceps weakness, when do you start your BFR training with them?
Let's say they are a patellar fracture that has been fixed, so they are in an immobilizer or a long leg brace. We'll wait for 2 weeks.
Okay, 2 weeks.
And we will start mobilizing them first active, assisted, and gentle passive range of motion. And then we'll start doing simple exercise like shorter quads, not shorter quads, but more straight leg raise. Mm-hmm. We work for some time, we just work on straight leg raise. And that's the only time we will do a quad set because I can't do anything else. But I try to avoid isometrics as much as possible with BFR.
But won't just for my understanding, with the isometrics, you won't get the atrophy. So won't you think that it would probably be beneficial?
I don't know, but I don't have many other methods of doing it. So after 6 weeks, I can do most of the things I want to do. But for the first 2 to 4 weeks or 6 weeks, I am limited in terms of doing BFR.
Understood, yes.
So sometimes in that case, we will wait. We'll wait for 4 weeks even, or 6 weeks before we do it. Okay. Many times we'll wait. We have no other choice, and we'll put them on muscle stimulation protocol at home.
Got it.
So NMES is a big part of our routine for patients like that.
Sounds good.
I don't have a lot of experience with cell swelling protocol, the passive mode. I haven't done as much. I've always done aerobic or strengthening protocol.
Got it. Okay.
So I have not, it's something that we are right now experimenting with our fresh ACL injury, starting with because they can't do a whole lot. So if they are injured and they need to get to a point where they are ready for surgery in that period of time, they have to do something. So we're experimenting with the cell swelling protocol for that group of patients.
Okay. Sounds good. Any other question anybody else has?
I see some questions here that are on the chat box. I think the first was about developing rhabdomyolysis. So as I told you before, my go-to is never go 80% for the lower limb. Always start at 60% or 50%. Get patient used to the cuff. It's the shock. The first time if you go 80%, many people have problem with that. Then avoid isometrics. Avoid patients with blunt muscle trauma. Luckily, touch wood, we haven't had a rhabdomyolysis or a compartment syndrome in the last 6 years. So those precautions have worked. It doesn't mean it won't happen tomorrow, but right now it hasn't happened yet. The second question was, low load exercise on cardio. The second question was, what is the effect on cardiovascular system? I don't know enough about its effect on direct cardiovascular system. Is it safe to do it in patients who have cardiovascular compromise? No, it's not safe. But its beneficial effects on aerobic exercise are well known on cardiovascular system. So that's the best answer I can give you. The third one is carcinoma patients. Can you use BFR? That is a question that I'm going to defer to somebody else who has done cancer patients. I don't treat them, so I can't tell you that question. The next question is, do patients develop DOMS or delayed onset muscle soreness? We see that more common when we have them do eccentrics later on. We do all our exercises 1 second concentric, 2 second eccentric. So there is some eccentric component to the free weights that we do, or even TheraBand. Do patients develop DOMS? Not all patients. We have about 20% incidence of, that's why we tell our patients that if you're sore, cancel that visit or change your visit to a next day or third day. And we never see a patient back to back ever. But we do see about 20% of the patients having some delayed onset muscle soreness. Whether they have lactic acid buildup, prolonged lactic acid buildup, I don't know. We haven't really done CPK. We did do a case study on EMG on patients to see if we caused any muscle damage. Was there a fibrillation potential in muscles after BFR? We didn't find any evidence of that in 2 patients, but it's a very small sample. The next question was, can we improve athletic performance through BFR for a normal person who is already athlete or a strong athlete? I think so. We have never used it for people who are functioning well already because they don't come to us. They usually don't come to a physical therapist if they're already normal. We don't get normal people. We only get abnormal people. But there is evidence of that. People are using it in the National Football League, National Basketball League. There are a lot of trainers who will use both the passive or a cell swelling protocol after before the game, after the game. There is actually evidence of reducing your the swimmers. They did a 100-meter dash swimmers in freestyle, and they found they cut their time by some seconds, or 1 or 2 seconds, and that's big for 100-meter dash. But is that doping? I don't know. Is that doping? Probably is. If you take a normal person and have him have their change in their blood profile and they do it. But I am hearing from trainers in the community that people do use it to improve their performance. There are some practical complications. What are the comments on elastic wraps? I personally have never used it. I have used it. I'm sorry, I shouldn't say that. I don't think it is safe to use in patient population because it's uncontrolled. And I will not allow it as a director of the department in a hospital to be ever used. Just an elastic wrap on a patient is not something I will ever use in a patient population. That was the last question.
Yeah. Hi, Dr. Anil. I have some questions for you.
Yes.
It was really a wonderful eye-opening session regarding BFR for us. I am aware that you are a musculoskeletal and a director of orthopedic rehab. I have a question stating that how about BFR in neurological patients? Can we apply it for neurological rehab? Is it?
I know it's an interesting idea. I know the patients who have neurological deficits have passive contractures that are also weak in their muscles. I personally don't have any experience on using it on neurological condition like stroke. We have a very compartmentalized department. We do only orthopedics and we have a very strong neurological team. But the idea, that's how discussions happen. 10 years ago, we didn't know what BFR was. When I first heard about it, I thought it was a sham. It was a bogus thing. I never believed it unless I used it myself. That I was very skeptical of all the hype that was going on. But it makes sense. But the question is, can you have measurable changes? Can you measure a change like walking speed, a tug, or something like that? Or can you strengthen their opposite limb? Because the walking is about using energy from the opposite limb. Can you use the opposite limb as a guide? I don't know. It's a very interesting question, and it's a very number of people that suffer from it. Maybe you can do a study. You are a neurotherapist. Maybe you can take 10 patients and do a study on looking at BFR for their uninvolved side and their involved side and see what happens. I don't know. It's a very interesting problem.
So I think you have given us a chance for further research in BFR in neurological patients. Is there any age group criteria for BFR? Can it be applied on pediatric population?
We are using it. We are a center for limb reconstruction. We are a very renowned center in the world for limb reconstruction. We get patients from all over the United States. And the youngest patient we have used it on is 8 years old. And my oldest patient is 78.
Thank you, doctor.
But we do a full screen. We do a full screen on everybody. We have a sheet that we go through, and we always involve our physicians in this decision-making process when you have really older patients. We sometimes talk to their cardiologist if we have to.
It's a very, very interesting session. Everybody is still on. It's almost 1.5 hours. We are on to 1 hour webinar. So everybody can put them questions on chat, and we would forward them to Dr. Bhave to answer it, and we can post it back to them. So in the end, I would like to thank the esteemed speaker, Dr. Bhave, who kept the whole podium motivated to be on a Saturday evening. And of course, moderator, Dr. Hannah, our other members, Dr. Nilambri, Dr. Raj Prasanna, who have taken their precious time out to make this webinar a rich experience for, I believe, the Indian community. Maybe most of us would like to be a part of your February workshop. So that'll be nice, and it can come like another wave in India to perform on, because we'll have huge numbers to work on. And yes, knowing your contraindications, keeping in mind, is an important aspect. At the same time, choosing the correct kind of patient and individualizing the treatment. I would like to express my heartfelt gratitude towards Dr. Anupam Sibal, our Group Medical Director and President of GAPIO, for his constant support and the vision that how such platforms can connect us globally and can enrich us with the knowledge of what all you people are doing there. We all can get connected, and getting such a platform is really a wonderful idea, and you accepting the invitation, all of you. So I'm really thankful to you all for that. At the same time, I would like to thank Dr. Anil Tandon, who is from GAPIO. He is with us. He's in Australia at this moment. And I believe for him, it is almost more past midnight. And he's on with us. So I'm really grateful, Dr. Tandon, to you to give us this opportunity to get connected and to get enriched with Dr. Bhave's experience, knowledge, and everything. So Along with him, I would like to thank all the organizers and our IT team, Mr. Ankit, who has been up and about keeping us into this forum that we are clear and we can see each other, we can listen to each other so well. So over and above all the participants who have been up till now, I'm really grateful to everybody to make this webinar such an interactive and a successful session. I believe there are a lot of take-home messages for all of us and to look forward to really get into such things more often. So have a great evening ahead. And for Dr. Tandon, midnight for you, past midnight. Thank you so much.
No worry. Let me thank all the speakers and particularly Dr. Bhave and everybody, Dr. Hannah and Dr. Jay Thakra and our friend from Chennai and all the audience. And I have my colleague also from Gapio. I'm in Dr. Anju Agarwal from Australia again. She has joined and many other dignitaries. Thank you very much. And it was a very, 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 very interesting talk. And there were many, things which were new for me to also learn. And it was really wonderful. And question answer session were, very enlightening. Thank you very much. Good night and have a good day and enjoy your weekend. Thank you very much. Thank you, Dr. Seema. Thank you,
Thank you
sir.
very much.
Thank you. Thank you, Dr. Anil.
Thank you, sir.
We
Thank you,
look
Dr.
forward
Bhave,
to you all
Dr.
for the
Seema.
next interesting session, similar session. So we look forward for the next session in the series to come maybe another quarter, and we would like to learn something new. Thanks a million, all of you, to be around and taking your time out. Good night.
Okay,
Good night,
Thank you
Dr.
so
Seema.
much.
All of you.
Okay.
Bye-bye.
Bye-bye.
Bye. Thanks,
Bye-bye.
everybody. Bye.
Thank you so much.
Yeah.
Bye-bye.
Bye.
I asked questions. Ew. How did he go about? But I asked a lot of questions. Thank you so much for he asked the question I had written.
It was amazing. Thank you so much for being there on such a short notice.
Thank you
a
so
million.
much, Dr. Seema, for having me there. It was a really learning experience for me too.
It's really amazing. You also taking it up to that level. Amazing. Thanks a million for your time.
Thank you.
Bye-bye.
Bye-bye.